Hello teacher, hello student. My name is Jorge Angel Lizado León. My topic is Rivaroxaban in patient with heart failure, sinus, writing, and coronary disease. Definition: Rivaroxaban is a oral direct factor XA inhibitor that reduces thrombin generation at doses of 10 to 20 milligrams daily. This agent is approved for a variety of indications, including the treatment and prevention of venous thrombosis and the prevention of stroke or systemic embolisms in patients with atrial fibrillation. Lower doses of Rivaroxaban, for example, 2.5 milligrams twice daily in combination with antiplatelet agents, have been found to reduce the risk of death from cardiovascular causes, myocardial infarction, and stroke in patients with acute coronary syndromes of stable coronary artery disease.
This was an analysis of the Commander-HF study, which had been published just a few months ago. And what we did in this analysis was based on the results in Commander. We recognized that mortality was the main driver of the primary outcome of that study, and that many of the deaths were due to heart failure. However, thromboembolic events still continued in the Commander study, and we felt that there might be a signal for Rivaroxaban favorably affecting those thromboembolic events. So we decided to do a sub-analysis and look at that a little more closely, and that's the basis of what we did. So in the study, we used the Commander population, and just as a reminder, these were all patients that had heart failure with reduced ejection fraction. They had chronic heart failure, but had experienced an episode of worsening and predominantly a heart failure hospitalization. And these were also patients that had evidence of coronary artery disease. They were in normal sinus rhythm, and they were then discharged from the hospital, and within 21 days of discharge, they were enrolled in the study and randomized to receive either Rivaroxaban at a dose of 2.5 milligrams twice daily or placebo on top of standard care therapy, and then they were followed at regular intervals through the duration of the study. So this is a post hoc analysis, and we used a composite of events that we felt would represent the thromboembolic risk that this population would be exposed to. So we incorporated myocardial infarction, ischemic stroke, sudden or unwitnessed death, pulmonary embolus, and symptomatic deep venous thrombosis. So this was a composite of those 5 components. The results were a 17% risk reduction, which was significant in favor of Rivaroxaban compared to placebo. During the course of the trial, nearly 15% of patients had experienced one of these events, and Rivaroxaban reduced the risk by 17%. So I think there's some important practical implications. Number one, for many years we had been looking at a possibility that thrombosis was a driver of the poor outcomes in patients who were hospitalized for worsening heart failure. And this clinical trial, Commander, showed that that's not the case. However, patients with atherosclerotic disease continue to have thromboembolic events. And the analysis that was done in this case shows that low-dose Rivaroxaban has a potentially favorable effect in reducing them. That's very similar to what was shown in both the COMPASS study and in the TIMI 51 Atlas ACS2 study, which looked at patients that also had coronary disease. So many of the patients because there's now an indication for using low-dose rivaroxaban along with aspirin therapy in patients post-ACS based on the results of the ATLAS study. If they were hospitalized for worsening heart failure, one would keep them on this therapy.
Application in medicine. Previous studies have suggested the inhibition of thrombin generation with rivaroxaban could be beneficial in patients with heart failure involving patients with a recent acute coronary syndrome. The dose of rivaroxaban 2.5 milligrams twice daily added to a background of dual antiplatelet therapy was associated with a lower likelihood of the primary end point the death from the cardiovascular causes, myocardial infarction, or stroke than placebo. In the cardiovascular outcomes for people using anticoagulation strategies, COMPASS trial in patients with stable atherosclerotic disease, the combination of rivaroxaban 2.5 milligrams twice daily plus aspirin 100 milligrams daily, but not rivaroxaban 5 milligrams twice daily alone, was associated with a significantly lower rate of the composite outcome of cardiovascular mortality, stroke, or myocardial infarction. The aspirin 100 milligrams alone. 14 analyses of subgroup of patients with a history of heart failure who were enrolled in the COMPASS trial suggest that they may benefit from treatment with rivaroxaban in combination with aspirin. It also used to prevent serious strokes of blood clots in adults who have atrial fibrillations or condition in which the heart beats irregularly make clots for likely to form in the body, possible causing a stroke that it is not caused by heart valve disease. Rivaroxaban is also used to prevent DVT and PEE in adults who are having high of P, replace surgery, or in people who are hospitalized for serious illness are at the risk of developing a clot due to decreased blood pressures, ability to move, or the other risk factors. Pros, a subgroup analysis from the trial suggests that patients with a history of heart failure were at a higher risk for cardiovascular events and derived greater benefit from rivaroxaban treatment or in patients with stable atherosclerotic disease. The combination of rivaroxaban 2.5 milligrams twice daily plus aspirin 100 milligrams daily, but not rivaroxaban 5 milligrams twice daily alone, was associated with a significantly lower rate of the composite outcome of cardiovascular mortality, stroke, or myocardial infarction than aspirin, 100 milligrams alone. Counts due to the result of this, we can affirm that involving patients with a recent acute coronary syndrome, rivaroxaban 2.15 milligrams twice daily at the background of dual antiplatelet therapy was associated with a lower likelihood of the primary point of the death from cardiovascular causes, myocardial infarction, or stroke than placebo.
When you feel well and you don't have symptoms, it's hard to imagine that something is going on in your body that may be harmful. We know with heart disease that there is a long asymptomatic period where people don't have any symptoms. While someone might have a heart attack at 70, the coronary artery disease has likely started when they were in their 30s for decades and decades. Unfortunately, there's no symptoms until it's too late and someone's had a heart attack or they have heart failure or they've had a stroke. The majority of people that have high blood pressure don't know it. In addition, high cholesterol, the vast majority of people don't know that, and you have to get a screening blood test in order to detect high cholesterol. The American College of Cardiology and the American Heart Association has a risk calculator for 10-year or lifetime risk of developing cardiovascular disease, and we recommend people talk about that with their doctor. If you lower your blood pressure by 20 millimeters of mercury, you halve your risk of dying from heart disease. If you lower your cholesterol by 50 milligrams per deciliter, you halve your risk of developing coronary artery disease. And if you're a smoker between the ages of 35 and 44, if you quit smoking, on average you'll expect to live 10 years longer.
Heart disease is still the #1 killer in the US. But there are some simple steps to reduce your risk factors. Cardiologists recommend following a few simple healthy lifestyle habits and getting regular screening tests to reduce cardiovascular risk.
By focusing on not smoking, getting regular exercise, eating a good diet, maintaining a healthy weight, and avoiding or treating high blood pressure, high cholesterol, and diabetes. Those 7 things can dramatically reduce the risk of developing heart disease even in people who have the cardiac risk factors.
The use of rivaroxaban in Ecuador. Xarelto filcoptop table 11 milligrams. Local name Xarelto filcoptop table 11 milligrams. Blood hematopiotic organs, antithrombic agents. Antithrombic agents, direct factor, XA inhibitor, mechanism of action. Rivaroxaban is a highly selective director factor, XA inhibitor with oral viability inhibition. Factor XA interrupts in the intrinsic and extrinsic pathway of the blood coagulation cascade inhibition brought the thrombin formation and thrombus formation. Rivaroxaban does not inhibition thrombin activate factor 2 and the no effects on platelets have been demonstrated. Therapeutic indication prevention of venous thromboembolism VTE in adults undergoing elective hit of NIP replace SUHEI treatment of the vein elective HIF, and if replace surgery treatment of deep vein thrombosis DVT and the pulmonary embolism PE, and the prevention of recurrence of DVT and PE in adults, prevention of stroke and systemic embolisms in adults with non-valvular atrial fibrillation, and with one more risk factor, CHF hypertension, 70 years old, diabetes, previous stroke of transient ischemic attack. Conclusion. In this conclusion, clinical practice records of a documental that dabigatran, rivaroxaban, and apixaban compared to BKAS are associated with a significant reduction in the index of international hemorrhage, with similar rates on ischemic stroke of systemic embolism. The selection of OAC depends on several factors appropriate. Indication, patient characteristics, comorbidity, concomitant medication, physical or patient preferences, etc. Thank you.
So I'm here at the European Society of Cardiology Heart Failure, and happy to present as part of the COMPASS team the sub-analysis of the COMPASS heart failure sub-study. Specifically, as we know, COMPASS was a large multi-center, multinational trial which found that use of rivaroxaban 2.5 milligrams twice a day plus aspirin was superior to aspirin alone in patients with chronic stable coronary artery disease for major adverse cardiac events, net clinical benefit, as well as mortality. In the sub-study, we looked at patients specifically with a clinical diagnosis of heart failure at baseline to see if they had similar effects. Indeed, what we showed is that according to the hazard ratios, the relative risk ratios were very consistent across the spectrum of whether or not the patients had heart failure or did not have heart failure. There was no significant interaction between those with or without heart failure, although interestingly we did see a significant improvement in absolute risk reduction for those patients with heart failure. Patients with heart failure had an absolute risk reduction of use of rivaroxaban plus aspirin as compared to aspirin of 2.4% with a number needed to treat of 42. This in comparison to patients without heart failure with an absolute risk reduction of 0.9 and a number needed to treat of 111. If we looked at the safety effects, that is major bleeding, we saw no significant difference between the patients that were treated with heart failure, although there were increases in patients treated with rivaroxaban plus aspirin as opposed to aspirin. Looking at the net clinical benefit, which weighed the risks and the benefits, the risk of major adverse cardiovascular events and serious bleeding, we showed that rivaroxaban plus aspirin did have a net clinical benefit very similar to what we had seen with the overall trial, but the absolute risk reduction was again reduced in patients with heart failure as compared to those without heart failure. So in conclusion, we see that the patients with heart failure actually had an increase in overall risk as opposed to those without heart failure, but a very consistent finding with the use of rivaroxaban plus aspirin as compared to aspirin. We'll be very interested to see with further analyses how the patients compare with preserved ejection fraction versus reduced ejection fraction. And also this will be a nice setup for the upcoming Commander-HF trial, which will look specifically at patients with reduced ejection fractions and coronary artery disease with the use of low-dose rivaroxaban plus aspirin. Thank you.